Okay, well, welcome to everyone. Thank you for joining this webinar. I am Leslie Appiah, OBGYN at the University of Colorado and Director of the Fertility Preservation and Reproductive Late Effects Program here. I'm also the chair of the Female Oncofertility Scientific Committee of the Oncofertility Consortium and have been helping to lead the initiative for putting these webinars on. Today's webinar is titled Preconceptual Counseling and Pregnancy Outcomes After Cancer. Our moderator for today's session is Dr. Terri Woodard, who is an associate professor in the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center. She holds a joint appointment in the Division of Reproductive Endocrinology and Infertility at Baylor College of Medicine and leads their fertility preservation program. And Dr. Woodard will introduce our speaker, Dr. Mildred Ramirez.
So hi, everybody. Thanks for joining us. It is my honor and pleasure to introduce you to Dr. Mildred Ramirez. When I arrived in Houston 10 years ago, she was one of the very first people that I sought out because she has been a tremendous help to me, our team, and our patients. She is a professor of obstetrics and gynecology and is board certified in maternal fetal medicine. She has over 20 years of experience in the management of high-risk pregnancies, specializing in cancer in pregnancy, cervical insufficiency, and first trimester screening. She earned her medical degree and completed her residency at the University of Puerto Rico School of Medicine. She then completed her fellowship in maternal fetal medicine at the University of Texas Health Science Center. She has been an invaluable, incredible resource for her patients. She gives them sound advice and they love her and wish that she would deliver them. And now I present to you Dr. Mildred Ramirez.
Thank you. Good afternoon. Thank you, Terri, for your kind introduction. And thank you for extending this invitation to share with you some of my limited knowledge. I do not have any conflict of interest, but I do have over 30 years of acquiring a lot of opinions and biases, which I hope to suppress today. I do not have a formal training in oncology, but since I reside in Houston, I learned at a very early stage in my career the need that we had for pregnant women, both for knowledge and medical care, during probably one of the most challenging periods of their life. A lot of knowledge has been acquired during these last 30 years, and I have learned a lot from the interaction from you guys, reproductive endocrinologists, the task that I was given today was to talk about preconception counseling and pregnancy outcomes after cancer diagnosis. So the objectives today are to discuss the role of preconception care in women with history of cancer, become familiar with the potential maternal and neonatal outcomes associated to their cancer or treatment, and develop a framework to properly counsel these women with a history of cancer considering planning future pregnancy. So my perspective is from the receiving end rather than the delivery end. Before we start talking about this specific population, I would like to talk about what preconception care is and what is the goal. A practice committee opinion describes that the goal of doing pre-pregnancy care is to reduce the risk of adverse health effects on the women, the fetus, the neonate, by working with the women to optimize their health, address modifiable risk factors, and provide education about a healthy pregnancy. There's 4 components in preconception care that include physical assessment, risk screening, vaccinations, and counseling. And this is a joint statement both with the Academy of Pediatry and your Society of Reproductive Medicine. The reproductive awareness includes not only family planning, and you guys are probably aware that about 45% of all pregnancies in the United States are unintended. Optimal interval between pregnancies is part of this reproductive awareness and timing of these pregnancies. We need to discuss potential environmental toxins, and those include things that are at home or at work, and includes exposure to things like pesticides, lead, asbestos, organic solvents, heavy metal, radiation. We also have to discuss proper nutrition and proper folic acid supplementation to try to reduce risk of congenital anomalies. We also need to discuss genetics, and that would include family history of birth disorders, even cancer genetic, carrier screening, and as well as the use of substance use, both of smoking and alcohol in the periconception period, and as well as medical conditions and medications that may be modified prior to pregnancies. We also need to discuss potential effects of infectious diseases, current vaccination, including now COVID, as well as psychological, social concerns that patients may have. The effectiveness of several of these interventions have been well documented, and not more like a folic acid supplementation in trying to reduce neural tube defect, immunizations in trying to prevent congenital viral infections, as well as management of hyperglycemia in the diabetic population, and smoking and alcohol cessation. Unfortunately, the interventions that we have identified are single interventions, and when we try to address the risk of multiple interventions and pregnancy outcome risk, we have very limited data. In 2006, the CDC and the ATSDR working group, and that is the Agency for Toxic Substances and Disease Registry, developed a care group and a panel on preconception care, and published recommendations of improving preconception health in the United States. They had 4 goals that were established, and those goals include the improve the knowledge and attitude toward preconception health, assure that all women of childbearing age receive preconception healthcare services, and reduce the risk by identifying adverse pregnancy outcome previously through interventions during this interconception period, as well as reduce the disparities in adverse pregnancy outcomes. The 10 recommendations that were given were encouraging women to have a healthy reproductive lifespan, increase public awareness of preconception counseling, preventive visits with development of professional guidelines for physicians, and some of these have been developed, increase interventions to identification of risk, have interconception care. In the United States, the uninsured population only have about 50% postpartum visits, so we missed that opportunity. The establishment of a pre-pregnancy checkup, also develop strategies to have insurance coverage for low-income population, integrate components of preconception into existing local healthcare programs that are already available, and develop research strategies and monitoring for those improvements. So that was a long time ago. Ooh, something happened. sorry. Oh, what happened? Okay. So how well are we doing? The Department of Health and Human Services initiated the Healthy People Initiative that had 4 very overachieving goals that including attaining high quality, longer lives free of preventable diseases, achieve health equity, create social and physical environments that promote good health, and develop healthy behaviors across all the life stages. They track approximately about 1,300 objectives, and of those of 42 topic areas of health, which include family planning, and some of the outcome measures rates in pregnancy. And they identified that between 2010 and 2020, the intended pregnancy is only 54%. There has been no change in improvement in family planning. Unfortunately, 24% of the general population receive preconception care. Even less, only 76% of the pregnant population receive prenatal care during the first trimester. In contrast, 78% of this population do receive some medical care, and we identified this as a missed opportunity that we can incorporate preconception care with other types of visits. We have done some improvement in the use of prenatal vitamins during these 10 years, but still about 20% of our population smokes. About 50% use alcohol during the preconception period. 52% are overweight, and only 50% of the sexually active population use contraception. So the March of Dimes identified that every health encounter should provide a window of opportunity for giving preconception care. And preconception care should be an essential part of every primary preventive visit. So, and they address an easy question for us to give patients: are you planning a pregnancy within the next year? With this approach, maybe we don't have to wait until our patients are seeing our maternal fetal medicine or our reproductive endocrinologist. The concept of preconception care rather than a visit, I think it's a process. And we are all aware of the limitations we have as providers. My reality in Houston is in one of the largest divisions of maternal fetal medicine, that we have over 30 maternal fetal medicine. The waiting time for just a transfer of care sometimes is a month. And our reproductive endocrinologists will voice that sometimes it takes months to see patients scheduled for a preconception visit. The preconception visits for maternal fetal medicine are competing with the time for maternal fetal medicine physicians doing other procedures or encounters that generate a lot more revenue for the department. So we have a conflict of how to provide this care for these women. When we look at adolescents and young adults that have undergone cancer treatment, there is a need for preconception for these women. Number one, we have survival from childhood and adolescent cancer is 80 or at least 80%, in some cancers way over 85%. It is estimated that about 400,000 cancer survivors are right now in reproductive age, and that after survival, future fertility is their second most important concern, with about half to 70% desirous of having fertility, future fertility. We also know that survivors from adolescent and young adult cancer have less likely to have a live-born baby. Review from Abelman in a large Ivy League institution, she looked at what type of contraception counseling was undergoing, these young adults were receiving. And she did a small retrospective cohort of 157 women. And she could only document that 33% of them, while ongoing oncologic treatment, received sexual health counseling. And only 48% of the actively sexually active adolescent and young adult were using contraception. And this is at time when they're receiving treatment for their cancer. Another cohort at Stanford, a little later, earlier in 2017, reported that only 10% of women diagnosed with breast cancer had documented contraception, and only 26% had documentation that they have seen a fertility preservation counseling. So it is not surprised sometimes that, unfortunately, we see these women, young adolescent, getting pregnant while receiving cancer treatment. Up to recently, there has been a lack of comprehensive assessment of those women who would benefit from high-risk obstetrician follow-up. A question sometimes asked is, do we need to send for consultation for maternal fetal medicine or not? Do they need to be followed by maternal fetal medicine? Who do I reserve? And a systematic review that was performed by the International Late Effects of Childhood Cancer Guideline Harmonization Group, or IGHG, it synthesized all the available evidence that we have and based recommendations for surveillance and counseling for young child and young adult cancer survivors during pregnancy and delivery. They looked at prior guidelines. They look at the concordance and the discordance between these guidelines. In the existing guidelines included both the American Childhood Oncology Group, as well as the Dutch, the Scottish, and the UK. They review approximately 28 documents, as well as 28 articles. And these are women that were diagnosed with cancer less than age 25. And what they identified was that they made general recommendations. Number one is that healthcare providers should discuss the risk of adverse obstetrical outcomes based on a specific cancer treatment exposures with all of female cancer survivors of reproductive age. Who needs preconception counseling? They think it's very important to tell the cancer survivors that we have no evidence to support that they have an increased risk of giving birth to a child with congenital anomalies. And this is high quality evidence. And in my experience, this is one of the first concerns that they voice, because I got chemo, my eggs are bad, and is my baby gonna have malformations? So we have high quality evidence to support the patient that there is no increased risk of congenital anomalies. Second, high evidence, quality evidence is that radiotherapy to volumes exposing the uterus, there is increased risk of premature birth and low birth weight, and moderate quality evidence of increased risk of miscarriage. There is also high evidence that there is a decrease in the risk of vaginal birth, and there is low level of evidence for postpartum hemorrhage, retained placenta, placental pathology, for intensive care unit admission for the neonate or neonatal resuscitation. Who needs a specific obstetrical surveillance? So they recommend that survivors treated with radiotherapy to exposing the uterus due to the risk of premature birth and low birth weight should follow high-risk obstetrical surveillance. And although we do not have interventions that can reduce that risk, at least we can monitor the patient and institute some treatments and surveillance to identify the growth restricted, or give steroids for long maturation for the patient at increased risk of preterm birth. It is also reasonable in their recommendations to offer evaluation for patients for cardiac surveillance if they have been exposed to anthracyclines or chest radiation, and that is moderate evidence. Unfortunately, there were no recommendations that could be given in terms of the frequency of the surveillance for women that had normal left ventricular systolic function before or during the first trimester of pregnancy. And that is a moderate level recommendation with very low quality of evidence. And I'll go through that a little more because you may be seeing different recommendations from different maternal fetal medicine specialties throughout the country. The panel recommended to stay alert for signs and symptoms of cardiac decompensation in these patients. And they also emphasize that women that had compromised left ventricular systolic function of less than 30% before pregnancy were more likely to have further reduction in their cardiac function during their pregnancy and their postpartum period. And this is independent of their lifetime anthracycline dose. And sometimes it's not reversible. So many of the data that we have through the decades came from case series, sometimes from single center institutions, some from self-reported outcomes from the patients when they were asked years later. There is a recent publication from a database from Ontario, Canada, by Sagardou. It was published this year, and they were able to look at a registry of all the cancer survivals in I think it was in Ontario, and they identified over 4,000 women with cancer. They matched them with at least 5 with no cancer, a 5-to-1 ratio. And these are women with cancer diagnosed prior to age 25, if I remember correctly. And what they identified was that the survivors were less likely than non-cancer patients to have a recognizable pregnancy. And they identified risk factors of which were associated with lower chances of survival, of pregnancy, and that include risk of cardiac radiation, alkylating agents, use of bone marrow allogenic and autologous transplant. They also identified the risk of being in an urban resident, a brain tumor diagnosis, and later age of diagnosis. So they were able to look at other risk factors associated to fertility in these patients much later in terms of other demographic factors that we didn't have in other series. In this study, they looked at primary outcomes. We're looking also at obstetrical as well as neonatal outcomes. And they identified that the survivors from childhood and adolescent cancer had a significant increase in severe maternal morbidity. The relative risk adjusted was 2.3, and cardiac morbidity with a relative risk of about 4. Of the 87 patients that had complications, severe maternal morbidity, out of those 4,000 women, 24% had risk of postpartum hemorrhage requiring blood transfusion. 25 developed a cardiac event. About 10% developed sepsis, and 27% require intensive care unit admission. There was no difference in these groups for the rate of preeclampsia, cesarean delivery, gestational diabetes. And between the survivors, the allogenic bone marrow transplant and older age at diagnosis had significantly more risk associated to severe maternal morbidity. So they are an increased risk of complications, and we need to be aware of the potential of these obstetrical complications in this patient population. For the neonate, the perinatal outcomes were again the same as previously reported: an increased risk for preterm birth. The rate of preterm birth in the group was 9.4. That's lower than the US preterm birth rate, but their comparator was only 6%. The patients that have had bone marrow transplant had increased risk of preterm delivery. And again, they did not notice any difference in terms of congenital anomalies, small for gestational age, low Appiah score, or admission to the neonatal intensive care unit. So in terms of, we talked about the maternal severe morbidity, but very important item is who are we going to monitor for the cardiomyopathy surveillance in childhood cancer. We know that there's an exponential increase of cardiomyopathy and symptomatic, both with exposure and duration. And the highest risk in those survivors that have a cumulative dose of over 250 milligrams per meter square, and that the increase of the cardiomyopathy increases with the dose, and that this cardiomyopathy is has been associated with all anthracycline derivatives. So not one is more cardiotoxic than the other, and that the combination of cardiomyopathy with chest radiation exposure increases though. The international late effect of childhood cancer, again, the same group, recommends that surveillance doing echocardiogram should be lifelong due to the increased cardiometabolic demands of pregnancy. Monitoring during pregnancy may be warranted. There is high evidence that survivors that have documented cardiomyopathy should be referred to cardiology, and as well as survivors should also be screened for other comorbidities. because it's not just a cardiomyopathy. Do they have hypertension? Do they have diabetes? Do they have, are they obese? And do they have dyslipidemia? Another component in these young adult survivors is that now we're adding other therapies that have not been prescribed for a long time, and we don't have as much data. And some of these new molecular target agents can be associated with early development of other cardiovascular risk factors, such as hypertension, diabetes, and dyslipidemia. Here is a cumulative a graph depicting the cumulative incidence of both congestive heart failure and myocardial infarction in childhood cancer survivors. The top graph shows the risk of congestive heart failure with anthracycline exposure during time and dose. And the bottom one is radiation exposure and risk of myocardial infarction and radiation. The risk of cardiac death has decreased significantly in this patient population from the 1970s to the 90s. It went from 0.5% to 0.1%, but the rate of heart failure and ischemic heart disease have not changed. And with the survivors getting older, ischemia becomes relevant. And although patients should be aware of these findings, at the same time, I'm very cautious not to scare them about the pregnancy, because we can tell them, well, you can go in heart failure and you can die. And I don't think that we have to put it in perspective. The cardiomyopathy from the anthracycline, in my experience, most of the patients that I see in consultation prior to pregnancy, they're asymptomatic. They're in what we call stage H. They're at risk of heart failure, but their heart looks normal, their function is normal, and they're asymptomatic. And this first stage of these patients, what happens is that they're slowly remodeling and thinning of the left ventricular wall with enlargement of the left ventricle diameter, increase in the left ventricular wall stress, and it's kind of like dilated cardiomyopathy. These changes then progress to then find changes, impairment in the left ventricular systolic function, and is manifested either by a lower ejection fraction or a decrease in the ejection fraction, shortening fraction, or they can decrease in both. And then they progress to a stage where we see the findings, but patient is asymptomatic, to the overt structural heart disease with symptoms that is refractory to treatment. If we look at another concept to look at, and in many of these women that are waiting for getting pregnant later in their lives, is the comorbidity and association. In this paper, we see the relationship between hypertension, whether we have a radiation therapy on the top, or if we have anthracycline exposure. So if you have hypertension and anthracycline, your relative risk of going into heart failure is much higher than if you do not have hypertension. So a lot of these young adult survivors, not only sometimes we recommend, please don't wait until your 40s to have your babies, because then we're going to have the consequences associated with other comorbidities. And we need to ascertain that when we're doing their counseling. What are the long-term guidelines for survivorship for patients that have had both radiation and anthracycline use? is if the exposure of anthracycline is less than 250 milligrams per meter square and no radiation, the routine screening can be done every 5 years. If they have radiation, is reduced to 2 years, and if they're greater than 250 is every 2 years. There is a role on having baseline EKG, and it is controversial how predictive the use of BNP is in this patient population, and I'll talk about that a little later. The children oncology group in that's late, I think the last publication is in 2018, developed a long-term care program for all of these young adults and children care programs. For me, it is invaluable to have, if I have the pediatric records in this patient population and know where they are in their follow-up, in their survivorship, in evaluating the patient. There's many important factors that are important in this patient population that we sometimes don't even think. Many of these patients have major psychosocial problems, whether it's depression, anxiety, and pregnancy may exacerbate these symptoms. Some of these patients have chronic pain, for example, patients that had amputation or neuropathy, problems with dental problems, with pulmonary problems, with neuropathy and the use of gabapentin. So it's very helpful if I have the evaluation, because many of these patients sometimes don't know what treatment they receive. And sometimes you are not sure that the current regimen of treatment is the same that they received 20 years ago. I have encountered patients that had surgery and pelvic radiation, and they didn't know because they were very small children and mama and papa never told them. So another concept is that many of these patients drop from their survivorship programs, and we're seeing them preconception, so we have to ascertain, are there increased risk of thyroid cancer? When was their last mammogram? So all of this gets incorporated in their care. From the maternal fetal medicine, we look at cardiovascular risk in a different way, and we have different sorry, I'm thinking of the word right now. Different criteria or predictors of how well they're going to do in pregnancy. We're all familiar with the New York Heart Association functional class, but as we talked before, many of these patients are normal in their activities. We can elicit prior cardiovascular events, and I always ask the patients, do they have prior history of arrhythmia, strokes, cardiac intervention, syncope, and heart failure. And then we have the most common complications during pregnancy for patients are arrhythmia and is questioning whether the lesion the patient have or the condition is it going to be accelerated by the pregnancy. In the last few years, we have given a lot of emphasis to cardiovascular risk in the pregnant population because it's the leading cause of maternal death in women. About 4.3 over 100,000 women are accountable, and this accounts cardiovascular disease about a quarter of all these deaths, and about 60% of them are preventable. So incorporating this cardiovascular screen assessment in preconception counseling is no-brainer. The problem is the instruments we have from them. The Sahara is congenital heart disease, so it's not applicable to the patient population we're talking now. The CARPREG looks at prior risk factors in the patient. It has been a system that has been fully validated with the stroke criteria. And the World Health Organization has its expert opinion, but also classifies the patient. And with the CARPREC, we give a risk of what is the risk of cardiac complication for the patient. We give them a score, and then we can anticipate or predict what is the cardiac event they're going to have. So if they score 1, they have about 27% risk of having a complication or event during that pregnancy. And if they have more than 1, it can be as high as 75. The World Health Organization classifies them by ejection fraction and lesions. And obviously, patients with ejection fraction less than 30 have about 40 to 100% of a cardiac event, and with a high degree of morbidity and mortality. Even class 3 with ejection fraction between 30 and 45% have about a 30% risk of severe morbidity. And therefore, that patient population, we do not want to achieve a pregnancy. Unfortunately, when we look at this series of predictors, they do not include our cancer patients, and neither to exposure to radiation or anthracycline. The cardiotoxicity from anthracycline has been reported in case series, as well as some prospective series and retrospective series. The first one was a 13-year-old. I have no idea why she was pregnant, but in 2003, we had a prospective series of 37 women that we did not identify any heart failure in these women. All of these women had a fractional shortening in their heart of over 30%, which is normal. In contrast, a retrospective series from Hines reported a rate of peripartum cardiomyopathy of about 0.3% or 1 in 500. A more recent series, and it's a small series from MD Anderson, they identify a much higher rate of cardiac event of about 16%. So again, I tell the patient that there's the potential of worsening and progression, but at the same time, we should not limit patients if they're especially asymptomatic with normal ejection fraction. And my bias is through my career, I have only seen one patient have deterioration of cardiac function, and she already had an ejection fraction of 40 when she got pregnant. The recommendations that you're going to see, it's going to vary. So some recommend, like Thompson, to consider whether high risk or not high risk, and do echo before every trimester, sometimes 1 month before delivery, 1 month after delivery. My bias is that this is an overkill on patients with normal ejection fraction and no prior events. I look at what surveillance they have been having, and usually I do, if we're able to get echo prior to their pregnancy, and if they're not symptomatic, I don't follow with echogram. But that is my other institutions. If they develop symptoms, then repeat, but I don't overdo it. Thompson also recommends doing BNP, and the sensitivity and predictive value of BNP in this patient population has not been validated. For us, ACOG, when they did assessment of what we needed to do for patients with cardiovascular disease, we see that history of chemotherapy. They do recommend, if patient has symptoms, to go ahead and do both baseline EKG, BNP, and an echocardiogram. So you may see different MFMs recommending different things. And for me, history of chemotherapy should be history of anthracycline, and we should include radiation in this group. let me see here. I'm losing track of time and I think I'm moving slow. So I just wanted to share with you guys that after we saw the cardiovascular events and maternal mortality, I embarked in a review of all our preconception at Baylor College of Medicine 6 months before and 6 months after pregnancy. I mean, after the new guidelines were established, and I tried to identify which women we were evaluating for preconception, were we identifying the risk of cardiovascular disease, and if we were ordering the proper workup for them. And to my surprise, in this 1-year study was that most of our preconception counselings at our institution are done by reproductive endocrinologists. And if you see 95% of women with first initial preconception is by you guys. And if they had risk factors that qualified, and that was a score more than 4, most of them were sent for either a cardiologist or MFM consultation, so it was appropriate. The use of ordering baseline EKG or BPN determinations or echocardiograms, we did not do very well. And in our population, only around 5% had prior history of chemotherapy. And more important for me was that the patients that were seen in preconception counseling probably is mostly related to infertility and advanced maternal age, and not due to other etiologies. So it kind of opened a Pandora box that even in academic centers, we might not be doing as best as we thought we were doing, and there's much room for improvement. These are the cancers that we did during that year consultation. So most of them were adult cancer patients. And I want to move into the adult cancer population. We have again, reduce likelihood of these patients getting pregnant, and the most common cancers in these patient populations were breast, gynecologic, and solid tumors. What outcome do we have in patients with adult cancers? Because this is different than the population of adolescents. There was a cohort that they link cancer registries with birth outcomes, and this comes from 3 states. I think it's Georgia, North Carolina, and Tennessee. They identified over 4,000 women age 20 to 25 that had a cancer during that period, and were able to carry pregnancy over 20 weeks. And again, they were less likely to achieve a pregnancy, but they were those that achieved pregnancy were older, more educated. They were having their first child, and most likely like they were married. So we had a lot of data from other information from this patient population. And this cohort probably has a significant proportion of Black women. So we have more data on this population. And unfortunately, compared to the counterpart, the outcomes is worse than in the whole cohort. The pregnancy outcomes in this group, we had enough cancers that they were able to separate them by cancer. And the breast cancer, the rate of preterm birth was increased, less than 37 weeks, as well as low birth weight. For cervical cancer, the rate of preterm birth was 28%, and that's quite high, and 10% in less than 32 weeks. So we have for cervical cancer, both small babies as well as preterm labor, and well as with leukemia, increased risk of preterm birth and low birth weight. So the evidence for preconception counseling is there. These women are not becoming pregnancy, and they're not achieving their reproductive potential as non-cancer patients, and they have increased risk of adverse outcome. They still have concerns about the health of their babies, and many of these women are not engaged with the cancer health system. So, and as well, primary care providers are frequently unfamiliar with this patient population, and I'm still see patients that they tell me, oh no, I cannot get pregnant because I had breast cancer, and it will make it worse. Where are we at, Terri?
I think we're
okay. So I was going to go through a case real quickly to work how I do this. I'm almost done, but I wanted you guys to be able to ask questions. So I picked a 39-year-old, newly gravid. She has breast cancer, diagnosed at age 35. It was a T2N1. ER, PR positive, HER2 negative. She had chemo, she had radiotherapy, she had mastectomy, and she was put on hormone therapy for 3 years. She got married at age 34, just a year before she got pregnant, and she wants to know. Her concerns are the most common. Should I stop tamoxifen? What is that going to happen? Am I have an increased risk of recurrence? Is my baby going to have congenital anomalies? Is the cancer going to come back? Because this is a hormonal positive. So on these patients, my approach in any of these consultations, I usually try to review the oncology records beforehand. And sometimes I have to familiarize with the specific cancer. I am not an oncologist, so sometimes I'm not certain of what is the risk of the recurrence or what specific treatment they got, what they consider are they in remission or not in remission. So sometimes I have to call the oncologist to know a little more about the patient. During the consultation, I find that it's very important to know why the patient is seeing me. Sometimes they answer because my doctor sent me. Sometimes they don't know, and other times they say, yes, Dr. Woodard told me I needed to talk to you. And sometimes this is where the relationship between the endocrinologist and maternal fetal medicine is important. We don't see ourselves, or at least I don't see myself a bad cop. I don't see myself as the gatekeeper to pregnancy. I do feel that I should counsel the patient about the potential risk in an objective manner, and for them to make the decision if this risk is acceptable or not. And then we move forward to optimizing their pregnancy. Do they need to be on better blood pressure control? Should they do a little more exercise? How we can get them to do the best that they can. Avoiding a morbidity, I don't think it's the chance, because I think that I'm not the person to tell them not to get pregnant because they may have a preterm baby. On the other hand, there are very few cases that we have to tell these women that they cannot be pregnant. And one of them is absolutely that patient that already has a cardiomyopathy with an ejection fraction that is less than 30, and serious considering not doing the treatment if it's between 30 and 45. Another patients that I feel very uncomfortable for them, and is patients that are not in remission, or patients that have that I tell them to wait a proper timing, because so that the cancer it's under control, because it makes it a lot harder to treat a patient that has a recurrence during pregnancy than a primary cancer. I provide them with the available outcome that we have, and sometimes I tell them there's only 50 cases of you, or I could only find 10 cases, or we have a registry like for breast cancer of 4,000 patients. So I give them that information. I lower their fear of congenital anomalies. I lower their fear of potential recurrence with the data we have, and we also optimize that timing of the pregnancy. You know, do your mammogram now, do all your survivorship timely, and then get pregnant, so we're not in the middle of not doing proper follow-up during pregnancy. And then I talk to them about how the obstetrical care will be modified for them. And then I make another recommendation, and I also tell the patients the importance that this is not a one-time visit. Sometimes they have to revisit because there are changes or the status or reports that need to be evaluated. So for this breast cancer patient, I told her that fortunately, out of 7,000 women that had breast cancer, they looked at the reproductive outcome. And I will tell them, you have a little higher risk of having a preterm birth, and a small risk of having low birth weight, and you have the same chances of having a completed pregnancy that somebody without breast cancer. You don't have a higher risk of spontaneous abortion. You don't have a higher risk of preeclampsia. And so I share them with this information. I also share them with the information of the 5-year disease-free survival. And I share with them the data, whether you're hormone positive or hormone negative, and that there's no difference in survival after of pregnancy after the treatment for breast cancer. I also discuss with them her concerns. She's on tamoxifen, and that is a conversation we need to know. I'm sure you guys are aware of the positive trial, and that one is looking whether interruption of hormonal therapy, endocrine therapy, would increase risk of recurrence. It started in 2014. I think they completed enrolling 518 women, and we're waiting for the results. I was not able to find them. I keep looking for them, but I hope that in the next few years we'll be seeing that they do not have a higher risk. Finally, I'm done here. I'm not going to talk about the assisted reproductive technology. You guys know more about that, but I also tell them, because sometimes they ask, is it going to be harder for me or not? And I tell them, your oncologist will talk about that, but we think that your live birth chances are the same whether you had cancer or not, and the same with the risk of relapse. The last one is in terms whether they have the BRCA mutation. We have new data that just came out, and at least for BRCA1, we don't have increased risk of recurrence. And in this registry, there were over 1,000 patients. And I conclude that I think preconception is essential part of our survivorship. I think there's definitely a need to improve access and attitudes to preconception care. I have to emphasize that cancer treatment may impact both the fertility and the pregnancy outcome, and they should be counseled appropriately. And we should avoid patients with congestive heart failure with poor ejection fraction getting pregnant, and that the preconception counseling with these women is individualized, developing a framework so we can proper counsel them all. And sorry that I was late. I'm behind. Thank you.
Thank you for such a very engaging, thorough talk. It's a big topic to cover. Right at that or maybe we can, there were a couple of questions in the chat that I can bring up.
Okay.
One question was, I think I can answer this one because it's more IVF related. If a patient went through pre-treatment egg retrieval, does it matter how long the eggs have been stored? And that answer is no. We think they can be stored indefinitely, so you don't have to worry about that. The next question, Dr. Ramirez, is what if a patient has had pelvic radiation? Is there a dose where you would not recommend pregnancy due to risk of preterm delivery?
With the radiation, some of the preterm delivery is also growth restriction and the remodeling. The data that we have in patients, it varies whether it was like a Wilms tumor, very young age, and whether it was like for other conditions like Hodgkin's and stuff like that. So I tried to look at what radiotherapy they really had. Some of these patients is the adaptation of the uterus, perfusion and all of that. And to be truthful, I have very few patients that have been irradiated that come to for preconception. But there's a dose response to them. And so there's a degree that they talk about in terms of the morbidity to the radiation, but we don't have that much data on the radiation. Some of these patients, when I discussed, and that is very difficult to predict what adverse outcome they're gonna have, that's when I discuss with my reproductive endocrinologist, do you think this patient needs a surrogate or not? And we have had patients that sometimes they will need donor egg, they don't have a partner, and they had major pelvic radiation. Is like, and unfortunately it's the cost of the surrogate, because for her probably a surrogate would be better for them.
Thank you. I know we're at the end of our time, but if people have other questions, I think we can answer those offline, but we thank you all for attending. Dr. Ramirez, thank you for such a fantastic talk and, imparting all of your knowledge and wisdom with us. Thank you.
And Terri, if they want, you can give them my email. If they have any specific question, I'm more than happy to answer if I know the answer. I try to time myself. I talked a little slower, so I tried to be on time for you guys. It's the first time I give this topic, so there was a lot to cover. So I apologize for you guys' time.
We appreciate you.
Thank you so much. Yes.